superior mesenteric artery. Another diagnosis that we should think about is an aortic mass, maybe a neoplasm extension, but we saw no masses in the abdomen, so we don't know where that thrombus came from. And the diagnosis should be made as we did with a CT angio. As treatment, we might offer to remove the thrombus with medication as conservative treatment. We may also offer to take it out with surgery, but the best option is always to go to your radiology center for a minimum invasive intervention, which is what we provided here for the patient. Here we see the initial control where we see no contrast going to the superior mesenteric. Here we see the inferior mesenteric, but here we see no branches. So we know there's no contrast inside the superior mesenteric artery. And after the procedure was finished, we see the contrast going not only to the main artery, but also the terminal branches. So we know we successfully removed the thrombus. And that's me, happy after the procedure. So that was my case. And if you have any questions, you can reach me at the Radford Dummies, or you can reach our radiology center as Radiología HU. Thank you very much for your attention. Estoy muy nerviosa. ¿Cuál es el tuyo? Me acordaba que decía no. Ahí estoy acá. Ya se estaba presentando.
Good morning. My name is Diego Mendoza. I'm a second-year resident here in the Hospital Universitario. And today I'm going to talk about an interesting case that caught my attention a few weeks ago. At first, the clinical case consists of a 44-year-old male with a long-term history of HIV with poor adherence to the treatment. He started 2 days ago with altered alertness, fever, mild headache. So after his physical examination, a CT scan was ordered, and it turned out to be normal. Therefore, a lumbar puncture was made, and the results were the following. He had a cleared appearance. However, the opening pressure was elevated, as well as the white blood cells were elevated, and it had a lymphocyte predominance. And the glucose and the protein levels were low, and the protein levels were elevated. So this patient had an MRI scan done after a normal CT scan, and the suggestive lumbar puncture results mainly in the search for meningitis. So here we have three images in flare sequence, where we can see an increased intensity in the basal cisterns located here, mainly in the quadrigeminal cisterns, the interpeduncular cisterns, and the chiasmatic cistern, as well as the sulci, mainly on the left cingulate sulcus and in the right superior frontal sulcus, located here. In this image to the right, we can see the difference between a normal sulcus, here to the left of the patient, and abnormal sulcus that contains hyperdense material inside of it. So these are three T1 weighted images after contrast administration that demonstrated enhancing exudate throughout the basal cisterns, as we can see here in this image to the right. Also, we can see nodular leptomeningeal enhancement in the subarachnoid space, seen bilateral in the frontoparietal regions, here and here, the perisylvian regions, and the temporal regions. This patient also had a thorax CT done, a non-enhanced CT thorax. Here we have two axial CT scans, the one to the right with a lung window and the one to the left with a soft tissue window. The one to the right shows profuse bilateral pulmonary micronodules with a random distribution, producing a miliary pattern, as well as a calcified right lower paratracheal lymph node located here. In a patient with HIV and this type of pattern, some of the differential diagnosis we should be thinking of is tuberculosis or a fungal infection. So this patient had tuberculous meningitis. This is the most common presentation of intracranial tuberculosis, and it usually refers to the infection of the leptomeninges. The transmission usually occurs through respiratory droplets. Thus, active infection usually begins in the lungs as a gun focus. This illness occurs at all ages. Mainly, however, in 60 to 70% of the cases, it appears in the first 2 decades of life. It has no gender predilection, and it affects worldwide 8 to 10 million cases annually. It is endemic in the developing countries. Nonetheless, it is re-emerging in the developed countries due to immigration from endemic areas, AIDS, and drug-resistant strains. It is worth mentioning that the central nervous system involvement only occurs in 5 to 10% of extrapulmonary TB, but are the most devastating of its manifestations. Some of the risk factors and the clinical presentation, mainly the most common risk factors are being HIV positive or having AIDS, having immunosuppression, diabetes, and being an alcoholic. And the most common manifestations are a low-grade fever. It varies much from fever to mild headache, confusion, lethargy, seizures, and also coma. This infection spread hematogenously from a distant focal point, usually from a pulmonary tuberculosis, and it lodges immediately deep into the pia, forming a rich foci. This foci can rupture into the subarachnoid space, forming an exudate. This purulent material is primarily located in the basal cisterns, in the frontal lobe, in the temporal lobe, and in the cerebellum, as well as the fourth ventricle. The prognosis of this disease is variable, and it depends on the patient's immune status as well as the treatment. Untreated tuberculosis can be fatal in 4 to 8 weeks, and even with treatment, 1/3 of the patients would deteriorate within 6 weeks. The treatment consists in multi-drug therapy that include isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin, and usually taken for a long period of time. Well, in the CT findings, in the non-contrast scans may be normal in early stages. However, in later stages, we can detect complications such as hydrocephalus and infarcts due to arteritis. In the contrast enhanced CT, we can see basal enhancing exudate and enhancement along the sylvian fissures, the tentorium, and the convexities of the brain. As we can see here, in this actual contrast enhanced CT in a patient with meningitis, demonstrating extensive nodular leptomeningeal enhancement in the basal cisterns. Now, in the MRI findings, first in flare sequence, we can see increased intensity in the basal cisterns and the sulci. In contrast enhanced T1 weighted image, we can see marked meningeal enhancement, bacillar prominence that may be nodular, and in the diffusion weighted image, it's helpful for detecting complications such as stroke or cerebritis. Here we have an example, an axial flare MRI with a patient with meningitis showing an extensive hyperintensity with the sulci located here and the basal cisterns. Here we have another example. This is an axial contrast enhanced T1 weighted image in a child with documented tuberculosis that shows thick linear enhancement along the midbrain and the temporal lobes. Note also the enlargement of the ventricles, that it's a complication of the meningitis. And this example is an axial contrast enhanced T1 weighted image that shows an homogeneous nodular enhancement. This is typical of a non-caseating tuberculoma, and the one posterior to it, it's a peripheral rim enhancement with central necrosis. This is typical of the caseating tuberculoma. It is worth mentioning that the tuberculoma is the most common parenchymal form of the tuberculosis and typically manifests as a lesion with a well-defined hypointensity, or a ring-like enhancement in T2 weighted images. The major differential diagnosis of tuberculous meningitis is pyogenic or carcinomatous meningitis, as well as viral meningitis. And these illnesses can be undistinguishable from one another by image. However, the carcinomatous meningitis is usually seen in older patients with known systemic or primary central nervous system neoplasms. The cerebral spinal fluid analysis remains the reference standard for diagnosis of the meningitis. Neurosarcoidosis can also mimic tuberculosis, as we can see a typical leptomeningeal or dural enhancement. It rarely causes parenchymal nodules, and it usually infiltrates the pituitary gland, the infundibulum, and hypothalamus. Okay. Here we have an example of an axial flare MRI in a 24-year-old patient with headache, fever, and vomiting that demonstrates a extensive high signal in the sulci due to pyogenic meningitis. And to the right, we see a coronal MRI that shows an extensive involvement of the fourth ventricle, choroid plexus, also shows the pia of the medulla, and the upper cervical spinal cord is thickening and enhancing. This is a case of neurosarcoidosis. It also has a mild enlargement of both lateral ventricles. So this is all. Thank you. Lo tenía abierto, ¿no? Tengo que hacer otra sesión. Ah, no.
Good morning, my name is Carla Reina de la Garza. I'm a second-year radiology resident here at the Hospital Universitario in Monterrey, Nuevo León, and I will also be presenting an interesting case. So first we have some of the patient's history. She's a 53-year-old female with a history of chronic kidney disease diagnosed in 2015, as well as systemic hypertension diagnosed in 2016. She had no other known diseases at the time of the examination, and she was under medical treatment for her hypertension, as well as hemodialysis for her kidney disease, which began in 2018. So she was admitted to our hospital on May 14 for a kidney transplant from a cadaveric donor. And the procedure was done with an end-to-side external iliac artery anastomosis on the right side. We were not told at the time where we were asked for our evaluation, but there were some complications during the procedure. During the recovery of the organ, the donor went on cardiac arrest and he had to be resuscitated. And during the engrafting on the recipient, the first anastomosis that they tried failed, so they had to undo it and then redo it because there was no perfusion to the organ. So those are some interesting and important facts about the procedure that have a long effect on the prognosis of the patient. So 12 hours after the surgery, we performed a Doppler ultrasound of the kidney. And in our institution, when we perform these sort of follow-up exams, we first review the native kidneys. So here we have 4 images of the right kidney and the left kidney. The right kidney had measurements of 6.2 by 2.6 by 2.1 centimeters, and the left kidney of 4.4 by 2.7 by 2.2 centimeters, which are both well below the normal parameters for the measurements that we should have in healthy kidneys. And we can also see that there's some clearly altered echogenicity in both kidneys, with the parenchyma being hyperechoic. And we have a loss of the cortical medullary differentiation, which are all in all, they are all signs of chronic kidney disease, which is what we already knew our patient has, so no surprise there. So we move on to the graft evaluation, and here we have a pretty normal looking kidney on first glance. It had a 10.9 by 6 by 4.9 measurements, as well as 163 cubic centimeters of volume, which are all normal measurements. And in this one, compared to the previous images, we can see that we can easily distinguish the cortex from the sinus and the hypoechoic pyramids. So we have a preserved cortical medullary differentiation. And although I know an ultrasound is a dynamic real-time evaluation, in these static images that I show here, we don't see any sign of alteration of abnormalities in the surrounding tissue, like a hematoma or free fluid or signs of infection, which are some of the earliest causes of complications in a post-transplant patient. So we need to look for those also. It is actually more common to have those sort of complications than vascular complications immediate to the surgery. So on the Doppler evaluation, we have here 2 close-up images of the color Doppler and the spectral Doppler of the polar artery on the upper third of the graft, and of the segmental artery in the middle third of the graft. In reality, we check the entire kidney. In our protocol, we check 2 arteries, 2 polar arteries and 2 segmental arteries on each third of the kidney. But we really, in this evaluation, the patient presented the same alterations in every single artery, so I didn't find it necessary to put the same images over and over again. And while here we can see a preserved color flow, we can also see that there are clear abnormalities in the spectral waveform, because we have an absence of the diastolic flow. And well, in this case, the thing we look for the most is the resistance index. And in this patient, in the polar artery, we have one of 0.89, and in the segmental artery, it was of 0.97, with a main resistive index of 0.89 of the whole kidney when we looked at all the arteries in our evaluation. And all those measurements are well above the normal, which in a post-transplant patient, it should be around 0.8 or under. So we already have in this patient something that is abnormal. And in this patient, not only did they ask of us the evaluation because it is a normal follow-up that we do in post-transplant patients, but also because she was anuric and her creatinine levels were still high. So she had a delayed graft function, which is defined as the need for dialysis within the first week of renal transplantation. Some of the risk factors that we have are infarction, acute tubular necrosis, rejection, perirenal fluid collection, and the most important one is the prolonged cold ischemia time. The longer the ischemia time is, the higher the risk of having a delayed graft function. And on ultrasound, we can see this delayed graft function as an absence of the diastolic blood flow and a high resistive index, which are both things our patient had. So what are some of the things we evaluate in the ultrasound in patients post-transplant? First, we look at the size and volume, and it should be similar to a healthy native kidney, but it can also be up to 32% larger in the first few days. So in our patient, it was normal. In echogenicity, we can have a slightly more echogenic sinus than normal, but we should always have a good cortical medullary differentiation, and our patient also had that. And the surrounding tissues, as I said, we can find some of the first signs of complication and rejection. We can have hematomas, we can have abscess, we can have signs of infection. So we have to always search for those. And on the color spectral, we always have to look for the resistive index as a sign of complication. Normally, in the Doppler flow, we should have a fast systolic obstruct and a slow decay into the diastole. And it should always have a forward flow, which means we should never have it under the baseline. So we have here a complication for the patient. Of all the 4 parameters that we reviewed, the only one that was altered in our patient was the Doppler. So with the 2 things that we found in our patient, we can have several options, but the most common ones are the acute tubular necrosis and the graft rejection. Acute tubular necrosis is due to a reversible ischemic damage to the renal tubular cells that happens before the engrafting of the cadaveric graft. It affects around 20 to 60% of cadaveric grafts in the first 24 hours, and some of the predisposing factors can be hypotension in the donor, a long, warm, and cold ischemic times, as well as cadaveric grafts, which our patient had. The prolonged warm ischemic time is the time that happens between the death of the donor and the cooling of the organ to 4 degrees Celsius, as well as the time it takes to do the anastomosis. And the cold ischemic time is the time that the organ spends in the 4-degree cool. So in our patient had around 10 minutes of warm ischemic time, which is normal, and she had around 5 hours of cold ischemic time, which is also normal. In the ultrasound, we will see a large kidney with compression of the sinus due to edema. We will also see loss of the cortical medullary differentiation and a high resistive index. And the other option that we have was a graft rejection. It can classify as acute when it happens between the 5th and the 7th day post-transplantation, and hyperacute when it happens in the first 5 days. Both types of rejection happen because of an immune response of the patient to the organ. But the acute happens because of a response by T cells, and the hyperacute happens because of a response from antibiotics. The ultrasound, the findings that we can have are also a large kidney with compression of the sinus, loss of the cortical medullary differentiation, and high resistive index, which are all the same findings that we can see in acute tubular necrosis. So really, by ultrasound, we can do the differentiation between one and the other. So we have these 2 options for our patient. 24 hours later, we performed another ultrasound, which had the same results: normal grayscale findings and an abnormal spectral findings with a high resistive index. During all this time, the patient was receiving medical treatment with steroids and immunosuppressants, but she was still required to do hemodialysis to maintain a proper kidney function. So on May 24th of the same year, a biopsy was performed here in our intervention department. It was done with a Trucco needle, and there were no complications during the procedure. The results of the biopsy were acute tubular necrosis. On May 25th, a post-biopsy Doppler was performed just to make sure that there were no complications like a hematoma. And we had the same results. We had the same high resistive index. And on May 28th, there was a gammagram performed, which showed decreased kidney perfusion and decreased kidney function. So we can have several complications in post-transplant patients, but we should always look at the time post-transplantation to think about what our options are. Like I said, on the first few days, we will have an antibody mediated rejection, and on intermediate, we will have a T-cell mediated rejection. Some of our immediate causes of complications can be artery thrombus, acute tubular necrosis, like our patient had. It could be a hematoma, and a compartment syndrome, and a vein thrombosis. And some of our intermediate can be signs of obstruction, lithiasis, urinomas, sepsis, and drug-related nephrotoxicity to the treatment of the patient post-procedure. And then some of our late causes of complication and rejection can be neoplasms of the donor or neoplasms of the recipient, as well as some post-traumatic injuries. So I found this case interesting because even though we don't have a lot of culture of organ donation in our country, there were two kidney transplants performed on the same day, and we performed the Doppler ultrasounds 12 hours later on the same patient, one right after the other, and both had signs of complication. This patient had the high resistive index, and the other patient had high velocities on the helium. And after 24 hours, we performed a follow-up ultrasound on both patients, and this patient still remained with a high resistive index, and the other patient had developed a hematoma. Both patients underwent biopsy by our department, one right after the other, and the results of this patient came back, as I said, with the acute tubular necrosis, and the other patient came back normal. The hematoma was resolved, and the high velocities on the helium were, they went back to normal. So it's very important to know the risk factors of the donor and the patient before the surgery, so that we can know what we expect once we are evaluating the kidney. In this case, the procedure had several complications. The donor went into cardiac arrest. He had hypotension. So that was some of the factors that we presented for acute tubular necrosis, and in this case, the patient presented with that complication. So the current state of the patient is that she is still hemodynamically stable. She doesn't have any signs of infection. She remains anuric and dependent on hemodialysis 2 times a week, and she is still in treatment to prevent rejection. Her physician is waiting until 7 weeks post-transplantation, which is actually next week, for a consult to see if they still give the kidney a chance to resolve the acute tubular necrosis, or if they will take the kidney out and try with a new transplant later. Actually, acute tubular necrosis can be resolved by itself, and you can keep the patient in hemodialysis to help with the prognosis for a long time. But in this case, the nephrologist told me that they were mostly considering to take the kidney out. So that is all for my class. I hope that we can have more cases of organ donation in this country, because really we don't have them, and it's a very important aspect that we should try to further develop. And that's all. Thanks.
¿Cómo se llama? ¿Aires? Sí, trata de algunas. Hi, good morning. My name is Eric Carranza Rodriguez, and this is my interesting case. So, starting off with the clinical history of the patient, we have a female patient of 55 years of age with a background history of acute pancreatitis that we don't know the date of the case, and that comes to the emergency department due to intense abdominal pain of 15 days or about 2 weeks of evolution that does not respond to painkillers. On the physical examination, the patient presented on deep palpation pain in the deep palpation in the right upper quadrant without any signs of peritoneal irritation. Afterwards, a contrast-enhanced CT scan was requested by the surgery team with a suspicion of an acute case of pancreatitis due to the background history of the patient. And just put the pointer. So here we have an abdominal contrast CT scan of the patient, and we are seeing a lung window. And as we can see on the lower portions of the lungs, we can appreciate some atelectasis on this patient and no other findings whatsoever. And we have here a venous phase of the study, and we're watching a soft tissue window. And I'm gonna let the story roll and address some of the findings real quick, and then we're going to focus on some of them. So already at the beginning of the study, we can appreciate a large lesion on the right liver lobe, and we're going to focus on this lesion for the main purpose of this case. So here we have the arterial phase of the study, focusing on somewhat of a liver window, and we can appreciate a large heterogeneous lesion that does not enhance at the administration of the contrast, but we can see or appreciate some of the contrast on the periphery of this lesion, but not that much. So on the venous phase, we can see that it is much more easily defined, and we can see that this is a large heterogeneous lesion that has enhancement on some areas that can be interpreted as septate, but in its interior, it has some areas that do not enhance that are acting like cystic lesions, as we can see right here. So we can say that this lesion has like a honeycomb appearance or pattern, and this lesion is located around the segments 4A and 8. And also, at the beginning of this study, we can appreciate that this lesion is conditioning a thrombosis of the middle hepatic vein, as we can see a hypodense tubular structure following its course. And we're going to wait for it to restart. And we can see right here a tubular structure that is following the course of the middle hepatic vein. And we can say that this lesion is conditioning this thrombosis. On the delay phase of the study, we can see that the portions of the lesion that previously saw enhancing are acting similarly as the rest of the liver parenchyma, and we do not see any kind of washout characteristics of this lesion, so we can think of a hepatocellular carcinoma, and the central portions of the lesion that did not enhance previously do not enhance in this phase. So here we have a comparison view of the three phases, which we can showcase the characteristic of the multicystic lesion, and we can confidently say that it is like that because of the lack of enhancement in some areas and the honeycomb pattern conditioned by the multiple septate. So the findings that we already found is the heterogeneous lesion located in the segments of 4A, 4, 8, and 8 that has some enhancement in some areas of the lesion corresponding with a honeycomb pattern, and that is causing a remodel of the capsule of the liver and a thrombosis of the middle hepatic vein. So with the suspicion of an abscess or a liver tumor, the surgery team worked with the interventional radiology team to take biopsies of the lesion, and the interventional radiology team obtained a blood sample and was sent to the central lab for examination. The tumor markers on the blood sample that was taken from the patient were unremarkable, and the sample that was sent to the central lab reported an insufficient sample for the diagnosis. The patient was then treated with antibiotics and painkillers, and after that, with a quick recovery, the patient was released from the hospital room to be followed up later on. And with the characteristics of this lesion and the quick recovery of the patient with the administration of antibiotics, we can confidently say that we're talking about a abscess or a abscess-like lesion. So with the pattern that we're talking about, I'm going to address that we highly suspect, although we have insufficient data or samples from the lesion, we can have the suspicion of melioidosis. So melioidosis is an infectious disease that is caused by a gram-negative bacilli called Burkholderia pseudomallii, and it can be found on the soil or on the surface of the water. It is a multisystemic disorder that can affect virtually any organ, but primarily it affects the lungs, followed by the spleen and the liver. And this organism enters the human host, most commonly through a pre-existing skin epithelial defect, and the majority of the human cases are from percutaneous inoculation. So melioidosis is a disease of the monsoon season in the tropics, with the greatest prevalence in the northeastern province of Thailand and at the top end of the northern territory on Australia. But some sporadic cases are increasingly being reported on tropical and subtropical countries such as ours in Mexico. And so the clinical presentation, melioidosis mostly affects adults with a predisposing condition, mainly diabetes, but other risk factors can be included in here, such as alcoholism, renal disease, cirrhosis, chronic lung disease, cystic fibrosis, and other causes of immune suppression. As many different organs or organ systems can be affected, the presentation is very variable, and patients may present with acute, subacute, or chronic illness, and each have different radiological findings. The lungs are the most affected organ, and most commonly the patient or the patients present with an acute pulmonary illness, often dramatic and often clinically more pronounced than imaging or suggesting findings would suggest. And the clinical manifestation ranges from a subclinical infection to a fulminating disease that can often have a multi-organ involvement and can cause even the deaths of the patient. And the definitive diagnosis of this illness is made by the positive culture of the organism on blood samples. So the ultrasound findings. Well, we will only be able to identify the melioidosis by ultrasound in the patient that have a visceral involvement in the abdominal cavity. As we're going to see later on the case that we already said, the lung is the most affected organ, and the spleen is the second most affected organ, followed by the liver and the kidney. But it can, as I already said, you can find different types of involvement in any kind of organ. On the ultrasound images, we can see that some lesions can be heterogeneous with an aspect of multiloculated appearance that have in its interior some anechoic characteristics, and this can represent a cluster of multiple lesions or a coalescence of multiple small abscesses. On the CT findings, we can see that, as we already said earlier, The lung is the most common organ involved by melioidosis, with pneumonia as the most common clinical radiological presentation, accounting for about half of the cases of melioidosis. But as I already said earlier, many of the patients come asymptomatic. As we can see here, as part of a pneumonia process, we can see a very large hypodense area that has a little bit of bronchogram in its interior, and a part of the consolidations. Other findings can be seen on the plain radiographs or computer tomography that consist in multiple generalized nodularity with the upper lobes predominance that can vary in size, that can enlarge, coalesce, or even cavitate, as we can see in the image down below. It is difficult to determine whether the lung consolidation is from a primary pneumonia or a secondary to septicemia. As I already said earlier, the patients can develop a very rapid development of this disease and can even cause a septicemia and even death. So the progression of the multicystic changes can occur, and many of these cases can result in a spontaneous pneumothorax or a bronchopleural fistula. So melioidosis can also occur on visual organs in the abdomen, most commonly in the spleen and the liver, and it can also occur, although far less commonly, in the pancreas, in the kidney, and the prostate gland, virtually any organ. The most common manifestations are abscesses, and they can be in a form of a single large or numerous microabscesses that can be affecting both hepatic lobes or the spleen, as we already said earlier. And as we can see in these two images of a contrast-enhanced CT scan on venous phase, we can see a very large, well-defined lesion that is heterogeneous, that has some enhancement in its interior, but does not enhance on some part of it. And we can see a little septae that go along all of the lesion, resembling a honeycomb pattern. And the honeycomb pattern has been reported to be characteristics for melioidosis in these type of liver abscesses that can be identified in liver abscesses that are more or larger than 2 centimeters. So, in conclusion, we can say that melioidosis is a multi-system infection. However, it has a penchant for the lungs, in the spleen, and the liver. The appearances can range from a honeycomb pattern in the case of the abdominal involvement that can be as a multiple microabscesses that can coalesce. And in the liver, the abscesses are often largely solid and very big. They can be septated with the appearance of the honeycomb. And this is important for the management of the patient because virtually all are not amenable for the percutaneous drainage. So that's the reason why our interventional team could not have the sufficient sample for the diagnosis. Thank you.
Ya se acabó.
Nice.
Nice.
We call the Ria Surmaliai.
Espérense poquillo para que le pague esto. Listo.
Oye, ¿quién es el señor de los micros?